Today we are going to talk about some basic topics from pathology. So you may find it easier when you are studying for any exams like USMLE, Plab, MRCP, if you are trying to develop your basic concepts. So starting from the growth adaptations, the cellular injury and the cell death that occurs continuously in our body, it's going. Some cells are continuously renewing, some cells are permanent, they do not regenerate, some regenerate. So our body is trying to be in a continuous balance through a process called homeostasis. So what happens during homeostasis, that our body tries to adjust, each and every cell of our body try to adjust according to the condition. The processes like temperature change, blood sugar levels, fluid balance, these are all controlled by a process called this process called homeostasis. So maintaining homeostasis is crucial for survival and optimal functioning of our body. So the steady state of the body's internal environment helps us to survive at the specific pH, that is 7.35, then at a specific body temperature 37.8 Celsius. So these are all very conditions that make us fit to live inside the harsh environments. So there is some positive feedback and negative feedback to which our body tries to control. An organ that is in continuous homeostasis process, when this physiological stress is placed on it, this increase or decrease or change in stress on an organ can result even in growth adaptations. So our cell also undergoes hyperplasia and hypertrophy. This is very important concepts in the basics, cellular injury and the changes in the body. What happens in the hyperplasia? There is an increase in number of the cells. So the increase in the number of cells is called hyperplasia, and increase in the size of the cells is called hypertrophy. So how hypertrophy happens? There is gene activation, protein synthesis and production of the organelles that leads to the enlargement of the cell. While hyperplasia and hypertrophy generally occur together, sometimes like when a mother is pregnant, in a pregnant uterus there is cell enlargement as well as there is increase in the number of the cells. So basically when there is increase in the number of the cells, like whenever we have some injury or cut on our hand, we have stem cells in our skin, so they regenerate very quickly. So basically stem cells play their role in the increasing the number of the cells. The tissues that are permanent like cardiac muscles, skeletal muscles, nerves, they cannot make new cells. So cardiac injury leads to the permanent damage there, skeletal muscle injury and nerves, although they undergo hypertrophy only but not hyperplasia. So in response to systemic hypertension, when we have systemic hypertension, our vessels have increased pressure, the heart has to put more pressure to increase to overcome that resistance in the vessels. The left ventricle has to pump with more force. As a result, there is hypertrophy of the cells of the left ventricle, and that we can see even on echocardiography, that the people who don't take their medicines, who don't control their blood pressure, how their heart size increases, and that leads to the heart failure in the end if there is massive hypertrophy of the heart. As there are some physiological changes that are going on in our body, there are also some pathological changes besides physiological changes. Physiology, like our cells are continuously damaging, they are regenerating, the old cells are dead, they are growing dead, and the new cells are forming on our skin. But on the other hand, the pathological conditions, like if we talk about endometrial hyperplasia, and that's an example of pathological hyperplasia. It can sometimes progress to the hyperplasia and even endometrial cancer. That's why the women who come to us, this case present us in different exam scenarios. That if a patient present to us with the old lady, 55-year-old, 50-year-old, 45-year-old, and she present to us and she has hyperplasia of the uterus, the endometrium, then we have to measure the size of the endometrium. If it is increasing and the size is enlarging with the passage of days, weeks, months, with the sequential ultrasound, then you have to take the biopsy to rule out that it is not growing into the cancer. In case if there is dysplasia is but when the cells start changing their normal shape and they develop features that is not healthy and can lead to cancer. So normal cells, when they undergo dysplasia, they can become cancerous easily. So in that case, we advise the women to remove their uterus so that they do not develop endometrial cancer that can metastasize easily and can take the life. So this is an example of the pathological hyperplasia. Another example that we can talk about does not lead to cancer of hyperplasia is benign prostatic hyperplasia. That's also called BPH. That doesn't increase the risk of prostate cancer. The men who are above the age of 50, they have difficulty urinating. The prostatic hyperplasia, it increases every 5 years. The prostate enlargement happens. There are some medicines, alpha blocker like prazosin, doxazosine. We give those medicine to reduce the size of the prostate. There are some among these that also called hypertension. So we have to be careful that which medicine in which patient we have to advise. So BPH, benign prostatic hyperplasia, unlike endometrial hyperplasia, does not increase the risk of prostatic hyperplasia. Now coming towards the topic of atrophy, that's also a very important topic in basic pathology. Whenever a cell is in under stress, like there is decreased hormonal stimulation to that area, there is disuse, and we use the word in muscles in accidental patients who are bedridden or ICU patients that are not using their muscles, there is disuse atrophy of the muscles, or whenever there is decreased nutrients or blood supply, the sick patient, chronically ill patient who are not taking their diet, sometimes they have the atrophy of the muscles, and atrophy means there is a shrinkage or decrease in the organ size. There is not only decrease in the size, but also the number of the cells are reduced in the atrophy. So this process occurs via apoptosis, that is cell death. There is some unique pathway that is sometimes asked in the basic pathology question, the ubiquitin proteasome degradation of the cytoskeleton and autophagy of cellular components happens. So ubiquitin proteasome degradation causes the degradation of the cells and the cell size reduces, and there is autophagy of the cellular component, mean the cell eats up its own cell contents. In ubiquitin proteasome degradation, the intermediate filaments of the cytoskeleton, they are tagged with the ubiquitin and destroyed by the proteasome organelles. What happens in the autophagy? The cellular components involves a generation of autophagic vacuoles, and these vacuoles fuse with the lysosomes. And we know that lysosome has hydrolytic enzymes. Those hydrolytic enzymes then break down cellular components. Next, we will talk about the metaplasia. We know that when stress is placed on something, anything that gets deformed. So similarly, and when a cell or an organ, it suffers some stress, face some stressful situation that is not according to the suitable environment of the cell, then cell undergoes metaplasia, that is change in the cell type. Most common type of that happens, one cell type changes to another, is the change in the squamous epithelium to columnar epithelium or urothelial epithelium. Sometimes we talk about a very common example that is also asked in some of the questions, is the Barrett esophagus. And we know that the lower part of the esophagus has stratified squamous epithelium, and the continuous acid reflux, the continuous acid stress that changes the internal condition of that cells, and those cells then are replaced by the columnar epithelium. So this change of the stratified squamous epithelium of the lower esophagus, esophageal and to columnar epithelium cells is an example, is a very good example of the goblet of the, is a very good example of the Barrett esophagus. And with the columnar cell, we know that our GIT has columnar cells with the goblet cells. So basically this stratified squamous epithelium, it is changed to the columnar epithelium with the goblet cells inside it. So the question is, why does this happen? Why the metaplasia happen? Actually, the metaplastic cells, they are better able to handle that stress, so our body try to adapt according to that condition. We know that every cell regeneration and change in the cell happens to this stem cells. So metaplasia also happens through the with the help of stem cells, which then produce the new cell type. It is said through a theory that metaplasia, it is reversible whenever the physiological stress, the acid reflux stops. Our cells try to become the non-keratinized stratified squamous epithelium again. So this treatment of gastroesophageal reflux may reverse the Barrett esophagus. But under persistent stress, metaplasia can progress to dysplasia and eventually result in cancer. For example, the Barrett esophagus may progress to adenocarcinoma of the esophagus. A notable exception that we can talk about is apocrine metaplasia of the breast. What happens in that? It carries an increased risk of the cancer. In apocrine metaplasia, basically there is a change of cuboidal epithelium of the breast lobules into the secretory apocrine cells, and these secretory apocrine cells contain abundant of eosinophilic cytoplasm. This basically happens among the women who are above the age of 25, and this does not lead to this metaplasia doesn't lead to cancer, just like the benign prostatic hyperplasia, that's a benign condition. Similarly, this apocrine metaplasia in the breast is also a benign condition, and there is no connection between this metaplastic change and a later growth of cancer, as I said earlier. It is said that vitamin A deficiency can also lead to metaplasia. We know that for vitamin A plays its important role in the cell regeneration, the skin regeneration. So vitamin A deficiency can also lead to metaplasia in a sense, because metaplasia is necessary for the differentiation of specialized epithelial surfaces as the conjunctiva, cornea of our eye. So whenever we are taking not taking enough of vitamin in our diet, or we are deficient in vitamin A, the skin, the thin squamous lining of the of our skin cells, or the we were talking about the eye conjunctiva, it undergoes metaplasia, and there is the excessive layers of the squamous epithelium, then that's called stratified squamous epithelium due to the deficiency of vitamin A. This change is also called keratomalacia, and you know that we often study about this condition called keratomalacia, and they sometimes they give us a picture of keratomalacia, and they ask us about this condition, that how does it happen, and sometimes they give us in the option due to excess vitamin A or deficiency of vitamin A. So we have to keep it in mind that keratomalacia is a condition due to the deficiency of the vitamin A. And where there is an excessive growth of the squamous epithelium, so the normal single thin squamous lining of the conjunctiva is then replaced by the stratified squamous epithelium. So it is important to know that vitamin A is necessary for the maintenance of specialized epithelial surfaces of the body. So a lack of vitamin A leads to trophic changes in the normal mucosal surfaces as well. The goblet cells are lost, and the normal epithelium is replaced by this abnormal keratinized stratified squamous epithelium. In addition, I was talking about the cornea. So substantia propria of the cornea breaks down and liquefies, resulting in keratomalacia as well, that we were talking about earlier. So cornea becomes totally opaque, which is one of the most common reasons for blindness around the world, particularly in the developing countries who do not take enough vitamin E in their diets. So dry eye is another condition, that ophthalmia, and sometimes let's go towards the next topic, the mesenchymal. So next we will talk about the mesenchymal cells, the mesenchymal stem cells, that are multipotent stem cells found in various tissue in our body, like bone marrow, adipose tissue, cord blood, and these mesenchymal stem cells are capable of differentiating into various types of cells, like bone, cartilage, fat. So they have a very important role in the tissue repair and regeneration. Mesenchymal cells also undergo metaplasia. A classic example of the mesenchymal metaplasia is myositis ossificans. That's a connective tissue condition within the muscles, where the muscles changes to bone during healing after trauma. So basically, mesenchymal stem cells, they play a role in regeneration, but when there is some metaplasia, then it will lead to myositis ossificans. There is a regeneration of the bone inside the muscle cells. So this is a very classic example and very important example of this. So the myositis ossificans, we sometimes classify into two types. The one is very common that we usually talk about is myositis ossificans traumatica. That is when there is trauma, then inside the muscles the bone regeneration happens. But there is another condition that's called fibrodysplasia ossificans progressiva. That's an inherited autosomal dominant pattern. That's that's not very much asked in the exam, but you should know about it. That and thus there is ossification that occur without injury, and typically it grows in a very predictable manner. Although this disorder can be passed to offspring by those afflicted with fibrodysplasia ossificans progressiva. It is also classified as non-inheritary. Inherited mean non-hereditary, as it is most often attributed to spontaneous genetic mutation upon conception. So 80% of ossification arise either in the thigh or arm, because these thighs and arms, these are more susceptible to injury and caused by a premature return to activity after an injury, basically. Other sites also that are most commonly involved in this ossification process. The myositis ossificans are intercostal spaces of erector spinae muscles, pectoralis muscles, gluteus muscles, and chest. Now let's talk about dysplasia. Dysplasia, as I said earlier, it's a disordered cell growth. It most often refers to proliferation of precancerous cells. So dysplasia is a condition before the neoplasia, before the cancerous stage, and that's why we also call these cells as precancerous cells. For instance, we talk about the cervical intraepithelial neoplasia, and we also give grades to that cervical intraepithelial neoplasia: grade 1, grade 2, grade 3, grade 4. So this cervical intraepithelial neoplasia represents dysplasia and is a precursor to cervical cancer. So like we said, normal cells convert into metaplasia, then dysplasia, and then into cancer. Cancer cells, this dysplasia, like metaplasia, is also a reversible condition. And as I was talking about the cervical interepithelial neoplasia, so basically there is these are histological grading of CIN1, CIN2 and CIN3. Cervical interepithelial neoplasia, in grade 1 there is mild nucleotypia, mean the cell nuclei they adopt a abnormal shape, and that we call that nucleotypia. There is also formation of the coilocytes, we call coilocytosis. That's a specific type of cell change as seen in HPV infections, and it is typically limited to the lower third of the epithelium. While in cervical interepithelial neoplasia 2, that's also called moderate dysplasia, it shows more pronounced nucleotypia and coilocytosis, and it extends into the middle two-thirds of the epithelium. In cervical interepithelial neoplasia 3, that's severe dysplasia, carcinoma in situ. Sometimes there comes a question in the MCQs, they talk about the carcinoma in situ. So cervical interepithelial neoplasia 3, grade 3, it's called carcinoma in situ. There is severe nuclear atypia in that, coilocytosis throughout the entire thickness of the epithelium, and if the external stress and condition change, if there is a HPV infection and we treat it, if the stress removes, then dysplasia is also a reversible condition. By elevation of the inciting trigger, inciting stress, this condition can be reversed. But if the stress persists, you delay the treatment, then dysplasia progresses to carcinoma. That's an irreversible condition. So next talk about the aplasia and hypoplasia. Aplasia, it's a failure of the cell production during embryogenesis. For example, we talk about unilateral renal agenesis, that one side of the kidney is not present, only one side of the kidney forms. Then sometimes there is aplasia of the limbs. Then hyperplasia is what? Hyperplasia, decrease in the cell production. It's just like opposite to hyperplasia. In hyperplasia, like if we talk about during embryogenesis, there is a relatively small organ size. Like if we talk about the Turner syndrome, in the Turner syndrome there are streaky ovaries, and the streaky ovaries, that is small ovaries, these are example of the hypoplasia. If we talk about the further examples of the aplasia and hypoplasia, then sometimes we read in many scenarios, in many cases, we talk about thymic aplasia, that is the absence of the thymus glands. In the newborns, we can see the shadow of the thymus on X-ray. But if there is congenital absence of the thymus, then it causes thymic aplasia. There is also pulmonary aplasia, absence of the lung. During hypoplasia, we also talk about the small eye in some syndromes or small brain size. So this small eye is called microphthalmia. This microphthalmia is an example of the hypoplasia. Similarly, for small underdeveloped brain and skull, we use the word microcephaly. And there is sometimes we use bronchial hyperplasia. This is another condition where the bronchial tubes are not well developed, these are underdeveloped, and this is called bronchial hyperplasia. So these are all examples of the hypoplasia. So these are all examples of the hypoplasia. Now let's talk about, so next we can talk about the cellular injury. So cellular injury occurs when a stress exceeds the cell ability to adapt. So the likelihood of injury depends on the type of stress, the severity of the stress, and the type of cell that is affected. There are certain cells in our body that are highly susceptible to the stress, and like neurons in our body, they can undergo ischemic stress. Due to hypoxia, the neurons can damage. There are some cells that are more resistant to external conditions, like our skeletal muscles. They have the ability to survive to some extent to the hypoxia. Sometimes when any organ of our body doesn't receive good blood supply, like renal, kidneys, if they don't receive enough blood supply, what happens is there is atrophy of the kidneys, and this happens usually in conditions like atherosclerosis, when in diabetic patients or hypertensive patient, when the blood vessels undergo atherosclerosis, they get narrow, and as a result there is not enough blood supply to the kidney and atrophy happens. Whereas this is a chronic condition. In a condition that is more acute, like if there is a embolus, it results in an acute ischemia. For example, in a coronary artery condition, if or in the brain, if some embolus goes into the cerebral region, then what happens? Then ischemia happens to the brain very quickly. Similarly, ischemia also happens to the, if the embolus is in the eye, that causes retinal artery embolus or middle cerebral artery embolus or anterior cerebral artery embolus. So the symptoms come very quickly. So ischemia happens very quickly. So we were talking about the cellular injury, and we said that when the cells are not able to adapt to the external or internal stressful environment, then the cellular injury happens. And the common causes of the cellular injury are the inflammation, and the inflammation can be due to any reason. For instance, infection can cause inflammation in the cells, and that can cause a cellular injury. Sometimes there are certain nutritional deficiencies, like malnourished patient and patients suffering from chronic conditions, patients who are anorexic. So the nutritional deficiencies of certain vitamins, minerals, salts can also cause a cellular injury. Hypoxia is a condition due to any, if the patient have some lung condition, or the patient is not delivering enough blood to the area due to cardiac condition or any reason, or if there is low saturation, hypoxia happens when the tissues are not receiving, the cells are not receiving enough of the oxygen. As a result of it, cellular injury happens. And sometimes there are accidental trauma, so traumas also lead to cellular injury. Then there comes the genetic mutations, and these genetic mutations can also lead to the cellular injury. So as I said, that slowly developing ischemia leads to atrophy, and we gave the examples of the renal artery atherosclerosis, where the kidney size reduces, renal atrophy happens when there is reduced blood supply due to atherosclerosis, like diabetic patient, hypertensive patient. They have very fast atherosclerosis that leads to the decreased blood supply to the kidneys, while the conditions that are acute, like embolus, they cause complete ischemia to that area, like we talked about renal artery embolus, retinal artery embolus, and the retinal artery embolus, and then we talked about the blood vessels of the brain, anterior cerebral artery, middle cerebral artery, posterior cerebral artery. They can have sudden embolus. So sometimes the DVT, the deep vein thrombosis, can also that thrombus can pass to the blood vessels to the brains. That's another topic. But about cellular injury, we have to keep it in mind that which conditions can affect our patients and their health overall. So we know that oxygen is the final electron acceptor in the electron transport chain of oxidative phosphorylation. So decreased oxygen impairs oxidative phosphorylation, resulting in decreased ATP production. When there is lack of ATP, that is, we know that whenever we are doing some work, we need ATP. ATP is the energy currency of our body. That is essential energy source. So lack of ATP leads to cellular injury. And then if we talk about that, why does the ischemia happens? Ischemia happens, why does the hypoxia happens? For ischemia, we know that what body conditions can lead to the ischemia, but first we have to talk about the causes of hypoxia, that is decreased oxygen level. So hypoxia is the low levels of oxygen in our body tissues. It causes symptoms like confusion, restlessness, difficulty breathing, rapid heart rate, bluish skin, because our cells are not receiving enough of the oxygen. As I said, that many chronic heart and lung conditions can lead to hypoxia, and it is a very life-threatening condition. Whenever a patient presents to us, they give us scenarios in the Plab exam, USMLE exams, MRCP exams, that what would be your first step, a patient presenting in an emergency with the hypoxia. So first we have to give that patient oxygen, but we also have to rule out the cause of the hypoxia, that why the patient is suffering from hypoxia, and or why the patient has low heart rate, blue skin, extreme restlessness, difficulty in breathing, why the patient rapid heart rate or rapid breathing, that is tachypnea. So confusion, headache, there can be any symptoms. Like in the carbon monoxide poisoning, when the oxygen is not delivered, the patient comes with headache and confusion. So hypoxia has many causes. The number one cause is the ischemia, and ischemia happens whenever there is decreased blood supply to an organ. Decreased arterial perfusion, for example, in atherosclerosis, as we talked earlier. Then decreased venous drainage, for example, Budd-Chiari syndrome. So they also give us in the MBBS prof exams, or in some of the scenarios in the USMLE exam, that is what is Budd-Chiari syndrome. And we have to keep it in mind. We most of the time we forget that it is the decreased venous drainage in the Budd-Chiari syndrome. So Budd-Chiari syndrome is a condition when an occlusion or obstruction in the hepatic veins prevent normal outflow of the blood from the liver. So whenever we see the radiological picture in the Budd-Chiari syndrome, what happens, that is, for instance, if there is a clot in the inferior vena cava or mets in the liver, it can affect the venous drainage of the liver. It can cause obstruction in the liver due to those blood clots, or occlusion due to the mets. So it leads to the liver congestion, liver enlargement. Patient can also present as a result with abdominal pain and ascites. So if the venous drainage that is impaired from the liver is not treated, then it can cause the liver failure, and that is very important condition. So we have to keep it in mind. Ischemia happens not only due to blockage in the arterial blood supply, but also a blockage in the venous drainage. The third condition that can cause the ischemia is the shock. So if a patient comes with a profuse diarrhea and the patient has reduced blood supply, then it's a patient is hypotensive, severe tachycardic, and or even in certain conditions of heat, like heat stroke or severe water depletion. These all conditions are an example of shock. Sometimes we also talk about these were the examples of hypotensive shock. We also talk about cardiogenic shock, neurogenic shock. So it can also cause poor tissue perfusion. So ischemia, these all examples of the ischemia lead to hypoxia and as a result cellular injury. Then we talk about hypoxemia, that's is a low partial pressure oxygen in the blood. When there is the partial pressure oxygen is less than 60 millimeter of mercury, and saturation that we check with the pulse ox is less than 90%, then we call this as the patient is having hypoxemia. So when does the hypoxemia arises? We know some of the patient lives at very high altitude, and there is decreased barometric pressure. As a result, there is decreased partial pressure of oxygen. So these patients can develop hypoxemia initially. And so how the body responds, the body start producing more of the RBCs in those people who live at high altitude. This is also a very common concept that is discussed in most of the exams and most of the books. So actually hypoxemia is an abnormally low level of oxygen in the blood. So more specifically we can say it is oxygen deficiency in arterial blood. So it can also caused by some pulmonary disease, as I talked, in high altitude. And if the patient is hypoventilating, then what will happen that increased partial pressure of carbon dioxide, increased carbon dioxide retention, and it will lead to decreased partial pressure oxygen. Then diffusion defects. If there is some issue with the lung and there is decreased diffusion of the oxygen across the barriers across the lung epithelium, then it also leads to the hypoxia. So in conditions like interstitial pulmonary fibrosis, IPF, the patient's lung epithelium is very thick, so there is a barrier to the diffusion of the oxygen. Then sometimes there is VQ mismatch, that is ventilation perfusion mismatch. When the blood bypasses oxygenated lung, for instance, in cases of right to left shunt of oxygen, air cannot reach blood. That is, there is either ventilation problem or perfusion problems. The VQ mismatch is a very important concept, and most of the pulmonary questions in each and every country exam, we give AMC, Canadian exams even, or USMLE, UKMLA, they always talk about the VQ mismatch in the questions. So VQ mismatch in a healthy normal lung, it's like equal to 0.8. What does that mean? It means that every 4 liters of air entering the lungs, that is the ventilation, there are 5 liters of blood flowing through the capillaries. So whenever the 4 liters of oxygen we inhale, there is 5 liters of the blood that is flowing across the capillaries to get ventilated by that oxygenated air. So VQ mismatch occurs when the ratio is disrupted, either with the insufficient ventilation for the blood flow, that is low VQ, or insufficient blood flow for the ventilation, that is high VQ. So low VQ means that ventilation is less and perfusion is more, and high VQ means that ventilation is more but perfusion is less. So this mismatch can lead to hypoxemia, hypercapnia, respiratory failure. So there are many causes of the causes of this VQ mismatch. Sometimes there is airway obstruction, like in asthma, bronchitis, or mucus plugging can restrict the airflow. So whenever we are even in anesthesia, whenever we are giving the general anesthesia to the patient is on the ventilator, we keep on looking at the ventilator respiratory curve. In case if there is some kinking of the tube, then it means the respiratory curve will spike. It will show there is increased obstruction inside. And most of the time I have worked in the anesthesia department, we see whenever there is some change in the curve and the curve is spiking, we immediately go to the patient or the surgeons who are doing the surgery. We ask them to please relieve that kink, or if they have touched our tube, then on adjusting the position of the tube, the patient's respiratory curves comes to the back. It can also shows that the patient is having bronchospasm or laryngospasm. So airway obstruction means the patient having low ventilation, because in kinking of the tube or in actual real obstruction like asthma, bronchitis, mucus plugging, the ventilation is not happening, although the blood is flowing through the capillaries, but the ventilation is not happening. So airway obstruction leads to reduced VQ. So that we call the VQ mismatch. Then there comes a lung tissue problems like pneumonia, pulmonary edema, or atelectasis. If the patient has pneumonia, that is, infection is going on inside the lung, or the patient is having pulmonary edema, or there is due to any reason, we will study about this in the respiratory system. There is 4 types of atelectasis. There are 4 reasons of the collapsed lung tissue. So this atelectasis can also lead to the low VQ. Then there are sometimes there is pulmonary embolism. We have some patient with a femoral fracture comes to the hospital department, the emergency surgical department, with a femoral fracture, and they suddenly start gasping. They are tachypneic, they have petechiae, and their vitals are not maintained. They are hypotensive, tachycardic, febrile, and this tachypneic patient with all these symptoms can be, shows that patient is having pulmonary embolism, where we go immediately for the further testing, D-dimers, and further imaging to rule out the pulmonary embolism. Then there comes the cases of the reduced perfusion. So pulmonary embolism can also cause the reduced perfusion, and a patient who have pulmonary hypertension, we sometimes have a patient with the different grades of pulmonary hypertension, where there is increased blood flow or high blood pressure in the pulmonary arteries. When there is high blood pressure in the pulmonary arteries, it can reduce blood flow to the lungs. So we have to keep it in mind. Then comes the next category of the patient who have heart failure. The patient who have heart failure, that is reduced cardiac output, and this reduced cardiac output can lead to insufficient blood flow to the lungs. Then as I talked about the interstitial lung diseases like idiopathic pulmonary fibrosis, where is the lung tissue get thickens and lung gets damaged, there is decreased ventilation. Then patient who have pneumothorax, collapsed lung, there is disruption of the ventilation as well as the perfusion, where we have to immediately perform the chest tube intubation to release that air so that the lungs can come to their original shape and size. Then the patient who are chronic smokers, hookah takers, and they have COPD, where is the emphysema as well as the bronchitis, airflow obstruction. So they also have this VQ mismatch. So these all were the important examples of the VQ mismatch. In such patient, we give the oxygen therapy, medication for the treatment of the underlying condition, and if required, we do go for the mechanical ventilation. If there is need to remove the blood clot or repair any tissue through surgery, we do that. So these all examples are the like high altitude, hypoventilation, diffusion defects, VQ mismatch, or there is if there is anything like that is affecting the oxygen level in the blood, these can cause the hypoxia. That comes the decreased oxygen carrying capacity. When the patient has decreased HP, either patient is anemic, iron deficiency anemia, megaloblastic anemia, metastatic anemia, or the patient has thalassemia, dysfunctional HP, or any other HP disorders where the HP is not able to carry the oxygen. So it can also lead to hypoxia. So basically, when the HP has decreased oxygen carrying capacity, basically we can divide into two. Either the HP is reduced like anemia, where the partial pressure oxygen will be normal, saturation of blood will be normal, but there will be the decreased number in the RBCs. So we have to rule out the cause of the anemia. Then in the patients who are like we read scenarios in the exams, and we receive patient with the carbon monoxide poisoning, where they keep their heaters on, or there's some gas leak in their systems in the houses. That carbon monoxide binds to the hemoglobin very strongly. It has increased potential to bind with the hemoglobin, and it doesn't let oxygen to bind with it. these all are the examples of the where the HP is not able to carry much oxygen and provide to the tissues, so it leads to hypoxia. So how can we differentiate that? Whenever there is anemia, we said that partial pressure oxygen and saturation of oxygen will be normal, while in carbon monoxide poisoning, where the CO binds strongly with the hemoglobin, the partial pressure of oxygen will be normal, but saturation of oxygen will decrease. So as I said, so we have to keep it in mind if there is smoke from the fires or exhaust from cars or gas heaters in the houses, as in most of the countries like Pakistan, India and many other countries. So we have to be careful. The patient with carbon monoxide poisoning, they have cherry red skin, and there is a headache because of decreased oxygen delivery to the brain, and confusion can happen, and it leads to coma and death even. Next comes the methemoglobinemia, where the iron in heme is oxidized to ferric form, Fe2 plus, ferrous form convert to ferric form, Fe3 plus, and we know that the ferric form cannot bind oxygen. So in this case, just like the carbon monoxide poisoning, the partial pressure of oxygen will be normal, but the saturation of oxygen will be decreased. There are certain drugs like sulfur drugs and nitrates that can cause the methemoglobinemia. And there's also comes a question that the patient with heart failure or heart condition that take nitrates medicine, they present with the sign and symptoms of the this methemoglobinemia, where the patient is cyanosed or there is chocolate colored blood, and there are symptoms of methemoglobinemia. Patient is saturation is dropped. So we have to rule the methemoglobinemia in the patient who are taking nitrates or sulfur drugs. So the treatment of for methemoglobinemia is also very important. We have to keep it in mind that we give intravenous methylene blue, which help reduce the ferric form back to the ferrous form. Next, talk about reversible and irreversible cellular injury. We know that hypoxia it impairs oxidative phosphorylation, and we know that oxidative phosphorylation is required for the formation of the ATP. When there is no oxygen, there is no oxidative phosphorylation. As a result, there will be no formation of the ATP, or there will be decreased formation of the ATP. So this low ATP, that's a nurture currency, it will dysregulate the cellular functions, and each and every cell in our body is performing the specific functions. There are organelles in the cells, and each and every organelle in the cell is also performing function. There are some ion channels in the cells, and they are performing their function. So cell doesn't have ATP. For instance, we know that cell have the sodium potassium pump. So when ATP will be not enough inside the cells, this sodium potassium pump will not work. So sodium will start accumulating inside the cells, and when we know that where there is sodium, there is water. So when inside the cells sodium will increase, the water will start gathering inside the cell. Then there is calcium pump. So when the calcium pump will not work, then calcium will also start building inside the cell cytoplasm. We know that aerobic glycolysis is also very essential inside our cells. That's a biochemistry thing. But when there is decreased ATP, then aerobic glycolysis will not happen, because aerobic glycolysis need the ATP. So this aerobic glycolysis will convert into anaerobic glycolysis, and when there is anaerobic glycolysis, we know that there is a result of lactic acid production, and lactic acid increased production inside the cells will lead to low pH. And we know that our body and proteins, they work at a certain pH, and if there is changes in the pH, then those proteins start degenerating and the DNA starts precipitating. So a lack of ATP due to hypoxia because the oxidative phosphorylation is not happening, will lead to low pH, and because the aerobic glycolysis is not happening, and as a result anaerobic glycolysis will start, lactic acid will produce, and pH will decrease, and denaturing of the protein will happen, and DNA precipitation will happen. So initially these changes inside the cells are reversible if these triggering effects, the external stressful environments, these are controlled. Then cell can come to its original form with the recovery, with the passage of time, and that's why we call it the reversible injury. So initial phase of this cellular injury is reversible, and sometimes in very basic questions, for instance the step 1, it's all based on the basic question, and it talks what is the end result of the reversible injury. So cellular swelling is hallmark of reversible injury. So there is water buildup due to sodium, because the sodium is not going out due to failure of the sodium potassium pump due to lack of ATP. So cytoplasm will swell, cellular swelling will happen, the microvilli that are present in the normal cells, and that will start losing, and membrane blabbing will start happening. So this is also a very important point that I'm going to share now, is the swelling of the rough endoplasmic reticulum. And the rough endoplasmic reticulum have the ribosomes on them, and ribosomes are the protein factory, they make the proteins. So swelling of the rough endoplasmic reticulum in the reversible cellular injury results in the dissociation of the ribosomes and decreased production of the proteins. Eventually, if the exciting factors, triggering factors, stressful environment is not removed, the damage becomes irreversible. When the damage becomes irreversible, then the hallmark of the irreversible damage is the membrane damage. So once the membrane damage, cells can not be repaired. So plasma membrane damage results in all of the cytosolic enzyme, they will leak into the serum. For instance, in the myocardial infarction, when the patient presents late, there is damage to the part of the heart because of the reduced blood supply. If there are some significant changes on the ECG like ST elevation, ST depression, we immediately go, and the patient has chest pain because of the ischemia, because of the hypoxia. We immediately go for the troponin level, troponin I or troponin T level. And these cardiac enzymes, these are the cellular enzymes, because in the irreversible injury, all of the cell's enzymes leak out into the serum. And whenever there is damage to the heart, there is leakage of this troponin from the cells into the serum. Additionally, what happens that calcium keeps on entering into the cell. That's sometimes asked into the exams. So there is leakage of the cellular enzymes because of the membrane damage in the irreversible injury, as well as there is continuously calcium entering into the cell. So next we comes towards the organelles inside the cells. So mitochondria, which is a main organelle that produces the ATP and energy, its membrane also start damaging. So there is loss of electron transport chain. We know that electron transport chain happens in the inner mitochondrial membrane. So there is loss of electron transport chain and ATP will not produce. Cytochrome C also start activating into the cytosol, and it activates apoptosis. So cell apoptosis starts. Then we talk about the lysosome membrane, lysosomal are the membrane, the damage happens, and there are hydrolytic. This question is asked, by the way, that what hydrolytic enzymes are present in which organelle. So lysosome had hydrolytic enzymes. When there is damage to the in the irreversible cell injury, the membrane damage happens. The lysosome leaks its hydrolytic enzymes into the cytosol, which in turn are activated by the high intracellular calcium. As I said, that calcium keeps on entering the cell. So this calcium will further activate these hydrolytic enzymes. So the end result of irreversible injury is the cell death, and we know that there are two pathways of the cell death. Either there is necrosis or apoptosis. The apoptosis is a programmed controlled cell death that eliminates cells without causing inflammation, while necrosis is an unprogrammed, often we call it the inflammatory cell death process, where the cell contents leak out. But we will go further into the detail of the cell death process. So the morphological changes that happens in the irreversible injury, where the cells may show nuclear changes like pycnosis, and pycnosis means shrinkage of the cells. Then karyorexis means the cell starts fragmentation, and then karyolysis, disappearance, where it starts dissolving. So this question is also asked in basic pathology scenarios. What is pycnosis? What are the steps of the morphological changes happening in the irreversible cell injury? So we have to keep in mind three words: pycnosis, that is shrinkage; then karyorexis, that is fragmentation; and then third is karyolysis, that is disappearance. So let's talk about the cell death processes. The morphological hallmark of the cell death is the loss of its organelles, and among these organelles the loss of nucleus happens, where there is nuclear condensation, as I said, and then karyorexis and then karyolysis, pycnosis, karyorexis and karyolysis. So necrosis, that's an unprogrammed cell death, where is the large group of cells, often occasionally after acute inflammation, undergoes unprogrammed cell death. So it can be due to some pathological process that is that is happening inside the body. The patient is undergoing some pathological process, so it can never be the physiologic, because there is always some acute inflammation associated with the unprogrammed cell death. So there are several patterns of the necrosis, and sometimes these patterns and types of necrosis also asked in certain questions. There is coagulative necrosis, liquefactive necrosis, gangrenous necrosis, caseous necrosis. So they ask that which organs undergoes coagulative necrosis, or under which conditions the liquefactive necrosis happens, or when does the gangrenous necrosis happen, and what is caseous necrosis and how it differs from liquefactive necrosis. So these are all very important questions being asked in the actual exam scenarios. Starting from the coagulative necrosis, here what happens, there is the necrotic tissue, it remains condensed, it remains firm, and the cell shape and its structure, or the organ that's undergoing coagulative necrosis, is intact or preserved by the coagulation of the proteins. But the cells who are the cells which are undergoing the necrosis, their nucleus disappears. Characteristics of the ischemic infarction of any organs except the brain, because the brain doesn't undergo the coagulative necrosis. All of our organs that are undergoing ischemic infarction, most of the time we talk about the wedge-shaped infarction, where there is vascular occlusion, and this wedge-shaped infarction happens in many of the areas. And this wedge-shaped infection is often used in the renal infarction. So basically, whenever there is a reduced blood supply to an area, and if that area is wedge-shaped, then we call it the wedge-shaped infarction. So whenever there is blockage of blood flow to a specific area of the kidney renal cortex, then renal infarction happens and it is wedge-shaped. Then in osteonecrosis, there is wedge-shaped area of the dead bone, and it occurs due to reduced blood supply, and is mostly seen in the femoral head when there is there is some embolus obstructing the blood supply to the femoral head area. Then osteonecrosis happens and it is wedge-shaped. Splenic infarction is another example of the wedge-shaped areas of necrosis. So this wedge-shaped area is often pale or discolored depending on the tissue type and the underlying cause. In the case of renal infarction, the wedge-shaped area of necrosis is pale and contrasts with the surrounding healthy tissue, and we have to keep it in mind. And if we talk about the osteonecrosis, the bone, that's also wedge-shaped. Whenever we ask the patient to undergo X-ray or MRI scans, then that wedge-shaped area is visible. In contrast, there are some red infarcts, and those red infarcts arise if blood re-enters a loosely organized tissue. For example, the pulmonary tissue or testicular infarctions, these are examples of the red infarction. There are some other also examples of the red infarction, like in the small intestine or in the liver, where there is loose blood supply to the tissue where the blood is re-entering, so red infarcts happen. And sometimes, most of the time, they ask in the questions that which organs or which area in the body undergoes red infarcts, and why do they appear red, and which organ undergoes pale infarct. So when there is extra blood supply to that area, then that area is red, and the blood is re-entering from somewhere else. We said that most of the organs undergo coagulative necrosis except the brain. Then what kind of necrosis happens inside the brain? So it is liquefactive necrosis. And what happens in the liquefactive necrosis? The necrotic tissue becomes liquefied. Why does it become liquefied? Because there is enzymatic lysis of the cells and proteins. And when there is enzymatic lysis of the cells and proteins, the liquefaction happens. So brain infarction is a kind of liquefactive necrosis where the proteolytic enzymes from the microglia cells in the brain, they liquefy that brain tissue. Next, the abscess is also an example of liquefactive necrosis, and this is asked in most of the NBME questions even. So proteolytic enzymes from neutrophils, they liquefy the tissue and abscess forms. So most of the patient comes with some hyperphalangeal abscesses, brain abscesses, skin abscesses. So these are all examples of the liquefactive necrosis due to proteolytic enzymes that are released from the neutrophils, and they lyse the cells and the proteins. Pancreatitis also undergoes a liquefactive necrosis where the proteolytic enzymes from the pancreas liquefy the pancreas parenchyma. So pancreas parenchyma get liquefied as a result of that damage that happens to the pancreas. So the bacterial infection in certain areas due to release of the neutrophil enzymes, they can also cause the liquefactive necrosis. Then we talk about the gangrenous necrosis.